Hi, I'm Ann Eglash, a family physician and a board-certified breastfeeding medicine specialist in Madison, Wisconsin. I'm a clinical professor at the University of Wisconsin School of Medicine and Public Health, and I'm also the CEO of IABLE, the Institute for the Advancement of Breastfeeding and Lactation Education.
Hi, I'm Dr. Lena Edelstein. I am certified by the North American Board of Breastfeeding and Lactation Medicine, a board certified pediatrician, and international board certified lactation consultant. I care for breastfeeding dyads in private practice in the outpatient setting. Hi, Anne.
Hey, how's it going?
Going great. I'm really excited to be here today with you to talk about some things that we found in our literature searches.
Yeah, I'm super excited to talk about your topic. I'm glad you gave me like a little bit of a spoiler alert ahead of time talking about burping.
Yes. So I will be presenting an article titled Science of the Burp, Understanding Aerophagia and Eructation in Newborns, written by Vincent James and Regis Savargaonkar. So eructation, that was a new word for me to have to look up, add it to my vocab.
I know I
So
never ever use that word with patients or even anything I write.
no, if you can't say it easily, don't use it with patients.
Right.
Um, so this article was published in BMG Pediatrics Open just this past month. And I picked this article first because I was drawn to the title. So I guess I do judge books a little bit by their cover, but really because burping comes up all the time during patient encounters.
Yes.
Like my baby is a good burper is stated proudly like it's a badge of honor, or it's really difficult to get the burp out, is said as if implying badness. I'm sure you hear this all the time too.
Constantly. I mean, burping is like one of the most common questions that people ask about in that first month.
Yeah. And I know what my own personal take is on burping. Like if I drank a can of seltzer, the last thing I would want is someone smacking my back repetitively. But, I honestly haven't seen much literature on burping, but you don't know what you don't know. And
Right.
I loved that an article was written to discuss this common baby practice further.
Yeah,
So
definitely.
this So this is a review article. It summarizes common burping techniques, their mechanical basis, and implications for infant care. And it highlights the lack of standard guidelines on the method of burping technique used and the lack of scientific evidence for the efficacy of burping to release the swallowed air, reduce regurgitation, and minimize infant colic. So I just want to reiterate that the authors did not write this report to act as a clinical guideline, but as a synthesis of the available research out there and to identify where the gaps in knowledge exist.
Sounds good.
So the burping techniques, they wrote that how they were all built on principles of anatomy, gravity, and emotion, really aiming to aid the passage of swallowed air from the stomach out through the esophagus, so coming up from above. Um, but noted that the burping techniques could also be used as a way to try to address other gut motility issues going on. So, whether it's slowed gastric motility or reducing reflux episodes. Um, and they described the how related to these gastric motility things, it could be different positions have different purposes. So, over the shoulder is a commonly used position for burping just due to parental caregiver preference and comfort, but how there's people told to put their babies into a right laying down, like a right lateral position for slowed gastric motility, or to the opposite side, to the left lateral position if you want to try to reduce reflux episodes. And some babies have both things going on. So that's a little bit confusing in and of itself because depending on what you're trying to address, you're being told to move your babies in all these different positions. The authors were only able to find one randomized controlled trial that looked at the effect of burping in their literature search. And this was from 2015. It looked at 71 dyads in the community setting. And the dyads were primarily breastfed. So that's a win, right? So it's in a population of patients that were interested in following. But there were slight differences between the groups in that 38% of the intervention group ever had a bottle, and the intervention that this trial was looking at was the being instructed on how to burp their babies. And 30% ever had a bottle in the control group, but it didn't really break it down further if it was a one-off thing or if it was half the feeds that the babies were getting. The primary outcome of this one trial was reduction in the event rates of colic and regurgitation episodes over 3 months. And it showed that burping may not significantly lower colic episodes and could even increase regurgitation in healthy term infants. This was the only randomized control trial that the review article authors were able to find.
That's interesting. I mean, parents is obsessed about it, like I need to get that burp out, otherwise I'm going to spit up. Um,
Mhm.
yeah, that's interesting.
So the takeaway from the author's literature review was that despite broad discussion around burping and including referenced reputable pediatric health systems putting out handouts like parental instructions on how to burp your baby, in healthy infants, there was no strong evidence that burping prevents colic or reduces regurgitation. And that for infants with other gut motility issues, more higher risk infants, it seemed that the positioning strategies may play a larger role than the actual burping occurring in terms of their comfort.
You mean like keeping them
Uh,
upright or keeping them on like one side versus the other to get the air?
right, like if they have, well, not to even get the air out, just in terms of improving gut motility, having them lay to one side. If
Oh,
they're
got
having
it.
more reflux, having them be on the other side, not so much the getting air out of their GI tract.
I see. Okay.
So the authors of the review article, they reviewed some of the common positions referred to. And reading this, it actually made me think about breastfeeding positions, how we come up with all these fancy names for different positions, even though the whole principle of proper positioning and attachment is more or less the same, the same features, just what we call them is different and how
Yeah,
we hold the babies. So the positions used, they described an over-the-shoulder technique, a position where a baby is sitting on the lap, lying across the lap, laying down on a flat surface, a caregiver walking or bouncing around with the baby, or the over the arm tiger hold, which made me laugh in my mind. I call it the Heidi hold because I remember with my son, he was really fussy one day, and my neighbor happened to check in on me, and her name was Heidi. And it was the first time I've ever seen a baby being held laying down on the forearm with their head kind of pointing
yeah,
outwards.
yeah,
And I don't remember if he burped or not, but I just remember he went from being really fussy to being really happy.
yeah. I call that
Um,
the colic hold.
oh yeah,
Yeah, yeah,
I never heard of it called that.
yeah.
So the review article summarizes a more in detail description of these different positions and their advantages and challenges. And I'm saying advantages and challenges in quotes because we just discussed that there was no evidence that burping actually results in less colicky babies and improves regurgitation. Um, and the authors then concluded that the burping is largely rooted in cultural tradition rather than evidence. So this review article, it highlights the mechanical diversity and practical considerations when reinforcing that no standardized evidence-based guidelines currently exist. So more of an example, when they were talking about the positions, they were saying, if you lie the baby down on their belly, it's putting some more pressure on their abdomen, which is more soothing to them. If you're walking around with them, it gives babies a rhythmic motion. So there was a justification without any evidence that those justifications actually did anything for the baby.
I see. Hmm.
So the strengths of the study, it's actually, I'm going to say its strength is also a limitation of it. There wasn't much scientific literature out there for them to review. Another limitation is that even with the positions they described, sometimes they use terms like gentle pats or caregiver walks and bounces, and that is so, so variable. I'm sure you see this in when you're seeing guides as well. There are some parents where they're just doing these really gentle, soft motions, and other ones where they feel like they need to have fabric underneath their hands to burp their babies because the padding is quite vigorous.
Yeah, and then they cup their hand. So it sounds like all boom, boom, boom. I know, and the baby's like reverberating. Like sometimes it's like, And whenever I pointed out to the parent, like, that's kind of harsh, they're like, oh my gosh, I had no idea, because they have probably watched grandma or mom or someone else burp the baby. And I mean, this is kind of tangential, but there was like a article on National Public Radio where they were talking about some research about like the brain trauma that happens with people who fire guns at a firing range, and just that little bit of a blast, like I'm not exactly sure what's happening when they fire their gun, but there's some micro brain trauma. And so I wonder, like, with this padding like so hard and the head like being jerked back and forth, like it can't be safe sometimes. I don't know if you've ever
I,
felt that way when you watch people burp their babies.
no, I agree. And I mean, I think anything where the baby's eyes are getting really big and their foreheads are getting furrowed and they're kind of just so surprised by what they're experiencing.
Right.
Um, I guess I never thought of it as impacting their brain, but just being more uncomfortable and more in shock by what was happening to their bodies.
Yeah.
Um, But what I would love to see is a study or a trial where it compared dietats who were following a burping protocol versus diets where there was no particular burping technique employed. But I would have different primary outcomes. Like the amount of my outcomes I would look for would be like the number of times a burp just comes and the time until the burp comes, because I do think it makes sense that babies do swallow air just between crying, feeding, just existing in general. But the caregiver burping the baby, it feels like an external intervention, meaning we're relying on the caregiver to make it happen, not just normal baby existence. So I do think that babies need to burp, but I don't know if the caregiver needs to burp the baby. Does
Right.
that make
Right.
sense?
Yeah, no, I totally agree, because when people ask me like how can you show me how to burp a baby? And I'll say, just put the baby upright and the just like bubbles come to the surface. They'll just come to the surface and your baby will burp. So I think what I'm hearing you say is like the relationship between pounding on their back or gently patting the back, whatever they're doing to do it, and the burp coming, is there any association, or is it just the fact that they're just upright and the burp comes out? Um, and I see us kind of gradually, this whole issue kind of gradually simmer away from parents' brains, and they get so much more relaxed about it by like 3 months, where they're like, they don't even bother burping their baby anymore. They're like, do I still need to burp my baby at 3 months? I'm like, no, just put the baby down, the baby will belch. And they're like, okay, because now they've moved on to like not be so freaked out about the burping thing. I'm not convinced that anyone needs to be burping their babies.
Yeah.
Yeah.
Yeah. So this article, the review article, it made me feel better about not having an answer to the question for like what is the best position to burp in. And it also made me feel better about telling parents that they don't need to get the burp out, but just hold their babies in whatever position they feel comfortable in or the baby seems most comfortable in. Um, and yes, that's all
Yeah.
I got.
Yeah, that's interesting that there's not much evidence. But sometimes you ever see those babies in the office where the baby's like nursing and then the baby's like really like agitated and fussy. And I'll say, oh, that's, I'm always curious to see what the parents say. And they're like, oh, I think my baby just needs to burp. And so then they hold the baby and they burp the baby, and then the baby gives out this big belch, and then the baby's like ready to feed again. I'm like, huh, this baby did need to belch, and this is something that the parent identified. But then, the question is, so number one, recognizing that there's something going on with having to like give a belch, which I think sometimes, like if I eat a really big meal, sometimes I feel like, oh, I need to belch. Like I'm going to feel better. My stomach will feel less bloated if I just belch. Um, I don't know how often that happens to other adults. It doesn't happen that much to me. But is it more likely to happen with babies? And why is it more likely to happen with babies? Maybe they're just like guzzling too much milk or something. Um, and then how often,
But
yeah,
But I mean, but what I'm hearing you say though is that the baby was feeding and the baby started acting fussy, and then the parents identified my baby is fussy,
yeah,
and then they gave the baby a pause versus oh, it's been 10 minutes. I need to make sure my baby burps before I continue feeding them, or I'm
Yes.
switching sides and I need to do it. So that to
Yep.
me doesn't feel like the caregiver was burping the baby, but it feels more like the parent was like responding to, oh, my baby's fussy. I'm going to do something.
Yeah. Yeah. And they're right. I mean, what I've noticed in these circumstances is that the baby belches and then the baby's ready to finish feeding. And so they have figured that out. So I guess there are some babies that just need to belch. And the question is, it's good for the parents to recognize it, but I'm hearing you say we don't need to get obsessed about it. Like they can just go from one breast to another. They don't have to. I mean, one advantage of belching, belching, for the baby between breaths is to wake them up a little bit. Um, and then if they're still awake, like you don't necessarily have to do that. Might be, and I do get a lot of parents saying to me, like, do I need to do this? Like, I never can get any belches out of my baby. And I'm like, yeah, it's normal. Like, not everyone has to burp. Um,
Yeah.
so maybe to summarize, how would you summarize this conversation?
Oh, I would summarize this as there is still a lot that we don't know and or we don't have a scientific backing for it, but reassuring that it sounds like we are not doing babies a disservice by instructing parents that they need to burp their babies.
That we're not doing them a disservice. That
Correct.
it's okay that for them to be told to burp their babies,
Oh no, it's okay that they don't burp their
but
babies.
they
On
don't
the
burp their
opposite,
babies. Right, right. Yes, that they don't have to burp their babies. There's no strong evidence that they need to be doing this. If they feel like their baby is more comfortable with a belch, they can do that. But they can just, in my mind, they can just hold the baby upright and let the bubbles come to the surface. Just give them some time and they'll just belch on their own. They don't have to pound on their backs. And to help parents realize that they don't have to pound on their backs, to stop pounding on their backs, because it's not probably might not be a safe thing to do. And, quite often when I tell parents that they don't need, when they say to me, I can't get my baby to burp and they're doing this, I'll say, like, you don't have to do that. And the look of relief on their face is like, this is great. I don't have to do that. It's like one more thing, like, I don't have to put the Vaseline on the circumcision anymore. I don't have to,
yes,
like X, Y, and Z, like all these rules. So, yeah, so everyone can just lay back and, you know,
yes.
500
You
years
don't
ago.
need to wake you don't need to wake a sleepy baby, like a baby who fell asleep while feeding. Do not wake the sleeping baby to get the burp out.
Right, right. And I think this is particularly important at night because people think, oh, it's like nighttime feeding is such a drag because then they feed and it takes like 10 minutes to get a burp. Like, no, just don't do that. You don't need to wait 10 minutes for a burp. Like, can you imagine interrupting your sleep just to get a burp out
Mm,
of the
no,
baby?
no,
Oh
no,
my
no.
gosh. Well, thanks for covering that. That's a good topic. Yeah. Awesome.
Thank you.
Yeah. So I'm going to just totally switch gears and something that's unrelated to burping, which is systemic juvenile idiopathic arthritis. So the title of this article is Breastfeeding Duration and the Risk of Systemic Juvenile Idiopathic Arthritis, a Cross-Sectional Study. And the first author is Luo. This was published in Frontiers of Nutrition just like in 2025. So let's talk for a second about juvenile idiopathic arthritis because it is one of the most common rheumatic diseases in children, usually occurring before the age of 16. It has 7 different subtypes, and some are systemic and some are non-systemic, which I'll talk about in a moment. So the authors describe that infancy is this critical window for immune system development during which nutritional exposures, particularly breastfeeding, has this like long-lasting immunomodulatory effect. So we know that breastfeeding just plays such an important role in how that immune system is going to develop over time. So the factors in breast milk, they provide passive immune protection, and everyone talks about antibodies, but we know it's so much more than antibodies because a lot of these immune factors will shape they'll shape the innate and adaptive immune responses. So, and this is something I didn't really know a lot about, that there's this innate immune response that's genetic, programmed, and then there's adaptive immune responses that occur in response to environmental exposures, right? In addition, breastfeeding promotes the colonization of a healthy gut microbiome, which plays a really important role in the way that that babies respond to the environment. There's been an abundance of evidence that breastfeeding does modulate that innate immune response when we look at how it affects immune-mediated diseases like type 1 diabetes, asthma, and atopic dermatitis. So getting back to like the systemic versus non-systemic, one of the big differences between these types of arthritis is that the systemic disease is thought to come from the innate immune hyperactivation, which can be modified by nutrition early on. So breastfeeding versus formula feeding, whereas the non-systemic disease has may have more environmental and other influences that play a role in its onset and disease process. So like being exposed to different, chemicals in the environment that can increase the risk of cancers and things like that. So the non-systemic juvenile idiopathic arthritis is really more like localized symptoms such as joint pain, swelling, or stiffness. And I've seen these toddlers periodically where, someone brings in a toddler and they have like the index finger has a swollen joint and it's warm, it doesn't bother the child a lot. And then there may be a swollen toe or a swollen ankle, and they're identified as having some sort of like juvenile arthritis, not necessarily rheumatoid, and they are put on like anti-inflammatories and they go along their merry way. And whether or not that's going to persist, it's hard to say. Systemic juvenile idiopathic arthritis is much more severe. I've actually never seen it. And it can have really more global symptoms like high fevers, joint aches, and a body rash. And it's a much more complex treatment and management protocol because it doesn't tend to respond very well to typical immunosuppressants that are used for autoimmune diseases. And these kids can get really sick with lung disease, and they can have something called macrophage activation syndrome, which I also never heard of before. And it's really rare. I don't know if have you ever heard of that?
I've actually seen it. When I was in residency, we had someone who was admitted for it, and but it ended up being that. But with the mast cell activation, um, so the mast cells, like they're usually associated with like a histamine response.
So this is actually macrophage as opposed to the mast.
Oh,
So the mast cell activation, yeah, that would be different. This is actually
I'm
macrophage
sorry.
activation. Yeah, it's something different that's associated with this juvenile idiopathic arthritis. And so it's associated with like high fever, enlarged liver and spleen, so hepatosplenomegaly, lymphadenopathy, so in swollen lymph nodes, a rash, bone pain, neurologic symptoms. Sometimes they can get confused or they can have seizures. They can have low blood counts. And they can also have abnormal blood clotting, so they can have a coagulopathy. So it's like really horribly scary systemic inflammation. And there's not a lot of evidence about the impact of breastfeeding on systemic juvenile idiopathic arthritis, probably partially because these cases don't come up very often. And so the authors were really interested to see if breastfeeding would play a role because this comes from the innate immune response, and breastfeeding probably has the biggest impact on that innate immune response. So the authors who are in Taiwan, they identified 500 patients who were diagnosed with juvenile idiopathic arthritis, and they were cared for by the Children's Hospital of Chongqing in Taiwan. I probably massacred the name of that hospital. And they were cared for between January 2018 and December 2024. And the patients were all diagnosed before the age of 16, and they were included in the study if there was enough evidence regarding their infant feeding history. So this was really like a really pretty much chart review. They did a medical records review on these patients, and they looked at a number of factors, like they looked at demographics, perinatal information, as well as the number of months that the infants that they as infants breastfed or received any amount of breast milk. which is amazing that they even had that data. Like, we don't collect that data in our systems in general. They also looked at like the disease progress, severity of disease, and the laboratory values. And so among the 500 patients, 450 had non-systemic disease and 150 had systemic disease. So in looking at the systemic disease, they found that patients with systemic disease had a significantly shorter breastfeeding duration as compared to those who had non-systemic disease. And when they looked at laboratory inflammatory markers, they found that like the longer they breastfed, the more negatively the better their inflammatory markers were in general, like their white count and their C-reactive protein and their neutrophil counts were not as high the longer they breastfed.
So what was long and short term breastfeeding? Like what did they define that as?
I think it was like over 4 months. Yeah, so it
So
was
under
not
four
like
months.
years. It was like around the 4 month time period. Yeah,
Okay.
yeah. So, what's interesting is that this is not the first study to show the relationship between breastfeeding and reduced risk of juvenile idiopathic arthritis. Actually was a study that was done among 91 patients with this disease in Brazil in 2015, and they found that breastfeeding beyond 6 months was significantly associated with lower disease activity and fewer joint deformities. And then there was another cohort studied in Sweden that found that children who breastfeed for less than 4 months had a significantly increased risk of developing juvenile idiopathic arthritis. So the authors described this theory that early life nutritional exposures help set the inflammatory set point of the innate immune system, which I thought was really cool to think about, like there being this set point of inflammation and that can be lowered by just physiologic feeding, which is breastfeeding, and that this set point can tip the balance towards or away from autoimmune inflammatory disease expression in among genetically predisposed children. So I think, these kids are predisposed to inflammation, right? And that breastfeeding can just tone that down and reduce that risk of expression of inflammation. Um, I just want to mention, the Agency for Healthcare and Research Quality, AHRQ, they came out with their report that was in 2025 that was entitled Breastfeeding and Health Outcomes for Infants and Children. This was a really long-awaited review because the last time they did that review was 2010, and we generally have relied on these incredible systematic reviews to really understand like the benefits of breastfeeding for infants or for the mother. And so what's interesting is that in that systematic, so the AHRQ review that just came out was a systematic review of just systematic reviews. Like it didn't look at individual studies, it just included systematic reviews. And they actually didn't include anything on autoimmune disease because there actually hasn't been any systematic reviews of infant or childhood autoimmune disease and breastfeeding. There's just not enough research on this.
Oh, wow.
So, I mean, and I think that when we look at these individual studies, like these studies on breastfeeding um, and juvenile, idiopathic arthritis, is it fair to just look at a couple studies? We have three now. We have this one in Taiwan, we have one in Brazil, one in Sweden that are showing this relationship. Is it enough to say that, hey, this can make a difference? Like if there's a family history of this or whatever the other risk factors are for juvenile idiopathic arthritis, you should breastfeed, or do we need to wait for a systematic review? Because so often we do rely on those systematic reviews. But I'm going to say this can be such a devastating illness that, this is a really good reason to, to at least initiate breastfeeding, right? For babies to be breastfed. And
100%. And I'm
yeah,
also thinking about if there's a genetic predisposition, it also is making me think about how you would counsel the parents because if there's a genetic predisposition to have it, there's an increased chance that one of the parents have it. And how is that going to impact their ability to comfortably breastfeed? Like if a mom is also experiencing arthritis like symptoms, is it harder for her to position her baby? Is it harder for her to get the pump on and off? And this is something that she could be doing to help modify her child's risk factor.
yeah, for sure. I mean, My understanding is that when someone, like in taking family histories of individuals, that if there's a family history of an autoimmune illness, it doesn't, like if someone, like if I have a patient who's like 20 and they have a parent with Graves' disease, or they have a parent with Crohn's disease, or whatever, an autoimmune disease, and they'll say, do I have the same risk of that autoimmune disease? I would say, well, you have an increased risk of an autoimmune disease. Like in general, you have a
Any
higher.
autoimmune one.
Yes, yes.
Yeah.
Right. However that will manifest, we don't know. So it does seem like, to your point, that if either parent have a risk, have an autoimmune disease, to just make sure to breastfeed that baby to change that set point for inflammation in the child, and getting that microbiome set in the healthiest way. I would just end by saying that for this piece, that when I look at my practice over the course of 30 years, my family medicine practice, the only children I had in my practice who developed an autoimmune disease under age 16 were not, other than Hashimoto, were not breastfed. I've had some kids with Hashimoto who breastfed, but in terms of severe arthritic diseases, Crohn's disease, juvenile rheumatoid arthritis, they have not been breastfed. So it's interesting. Yeah. So something, so is this one of those things that we're not going to find in the AHRQ review, but it's something I think that we need to talk to families about.
Definitely. And hopefully we'll have more information on it. So when they come up with their next update of that in the future, something will be able to be included.
Right. And I think that as, in so much research that we see when we look at infant illness, I will look at the studies and say, well, did they look at how often these babies were breastfed? Like, do we have that data? And I'm hoping that as we have more physicians trained in breastfeeding medicine who are maybe getting involved in clinical studies at their institutions, that they will always have that lens on of thinking about infant feeding and how infant feeding plays a role in infant health over time, and maternal health too, right? I mean, we know that that's a huge issue. So great. Any last words?
This was fun. Thanks for having me.
Yeah, it was really good talking to you, Lena. Take care, and I'll see you again next month.
Bye, Anne.
Bye. Thanks for listening. If you have questions or comments regarding this podcast, please contact us at admin@lacted.org. That's LACTED.org. You can also post comments or questions on our Breastfeeding Medicine Facebook page, and we will have links to our articles on the page. We have boatloads of breastfeeding education opportunities at our website, lacted.org. So come check us out and become a member to join our community.